Good morning, friends. We are here for the course on Phakic IOL. Learn it from the masters. With me, I am Dr. Purendra Bhasin. With me, we have Dr. Partha Biswas, who will be speaking on the correct way to do ICL and toric ICL. Then Dr. Ramamurthy, who will be adding his experience by Indian Phakic lens. Then Dr. Bharti, Sudhank Bharti, with managing complications in Phakic IOL, and Dr. Sri Ganesh, who will be speaking on managing challenging situations of Phakic IOL. So, Phakic IOL is in practice in vogue, and I have been practicing this for last almost 18 years. And before that, I used to use very size lens, which was an iris claw lens, and I did almost good number of cases, around 30 odd iris claw lenses, but there were limitations and many issues, and we were not able to correct toricity. Then it was in the anterior chamber, so case selection was also a challenge. So now we have moved completely to the posterior chamber phakic lens. So before starting, before going further, my first talk, I will be taking you into how we should plan, and that is very important. The pre-operative workup planning of a phakic IOL, because the technique per se is not very difficult, but the pre-operative planning and case selection is one of the most challenging and important thing. I don't have any financial interest in this. A phakic lens is an intraocular lens placed inside the eye and in front of patient's natural lens to correct their refractive error. And this could be the angle supported, iris fixed, or the posterior chamber phakic IOLs. This course mainly will add on to the posterior chamber phakic IOL. Before taking you further, let me show you a case where you will get an orientation how it is done. We make a 3.2 millimeter incision. The lens comes in a BSS solution, and this is the cartridge. This lens is very thin, and with front loading technique, we pull the lens in the cartridge nozzle, and with the soft tip plunger in the cartridge and injector system, the lens is pushed inside the anterior chamber in the presence of viscoelastic, and the four haptics, this is a plate haptic lens, the four haptics are then pushed behind the iris with a special spatula. And this is a toric lens, and the axis of the toric lens is aligned with the marks which we are doing, or in this particular case we have used Varion, and the rotational stability is very high in these cases, in all these cases. So the quest for the phakic lens started way back in 1953, and various prototype, various designs were developed, and but none of them were successful because of the poor position, poor design, poor quality, and everything. So then came the iris fixed very size phakic IOL, which was FDA approved, made up of PMMA material. The results were highly predictable and was relatively safe, but we required large incision, which induced astigmatism. Large means 5.5 millimeter incision, and endothelial cell loss was one important issue which was there. But if your this thing was good, case selection was good, there was not edge clear and disinclination, as in this particular case you can see one haptic is dislodged and lying in the anterior chamber in the lower side. So this was was commonly seen. Then the flexible model or foldable version came, which didn't got any FDA approval. And acris of Cache lens also came some 8-10 years back, but it also didn't got popularized. So the the present phakic lens, which is the plate haptic type of a lens, the prototype was developed or given by Fedorov from Russia in the year 1986, and the first this was a collar button or mushroom configuration. The advantages of posterior chamber phakic lens is that it can surgically correct high degrees of myopia that cannot be corrected otherwise. We can correct up to 18, 20 or even more. It may be performed in patients who are not the candidate for LASIK due to corneal irregularity or thinness. So in low myopes also we can use this. And it is less likely to cause or contribute to dry eye. Sir, you can come, Dr. Bharti, please come on the dais. Less likely to cause or contribute to dry eyes, because surgical there is no the damage to the corneal nerves. It remains behind the iris, so there is an excellent cosmesis, and it is invisible to anybody from outside, and it is far from the endothelium, close to the nodal point of the eye, so there is a gain in retinal size image. Located in the sulcus, stable location allows for toric design and easily removable. This is the most important thing, exchangeable or reversible, no fixation into tissues, and does not alter shape or remove tissue and lead to a corneal based problems. It has a central vault, and as you can see here, this is the vault, means the central part is anteriorly this thing anteriorly, the convexity is there. It is foldable, that is the good part. It absorbs UV radiation, but definitely there is a sizing issue which we'll be discussing later, and it is made up of a polymer material. Coming to this material is biocompatible, and it attracts a layer of fibronectin. As you can see, the dashes are there on the surface of the lens. Fibronectin inhibits the deposition of other proteins which are present in the aqueous humor. The polymer lens is not recognized as a foreign body. So even in the long run, in 20 years, 15, 20 years, you don't see there is any deposit or pigment dispersion or pigment on the surface of the lens, unless until it is touching the iris. So the transparency is very good. It is maximum. Molecular size is 100 nanometer, and that's why it gives a better optical performance, excellent transmittance, and low reflectance pattern. It is very flexible, foldable, and can be easily injected through small incision. And it doesn't. There is a very less amount of glare and halo, and sometimes it is there in the initial phase due to the presence of center hole. Coming to the Centraflow ICL, which belongs to the ICL V4 family, it has a 360 micron central opening, which is designed to restore more natural aqueous flow and eliminates the need for iridotomies. Earlier, we had to do one iridotomy either by YAG laser before or during the surgery itself. But now, because of this 360 micron central opening and a tube opening on the side, which are acts for the redundancy, it maintains the balance, equilibrates the fluid aqueous balance in front and behind the lens, and that's why the nutrition of our crystalline lens is not hampered, and the quality and the clarity of lens and the development of cataract is further. Sir, please come on the dais, Dr. Ramamurthy sir. And this helps for the OVD removal and provides redundancy for the central optic port. The EVO, now what we are using is EVO plus Vision ICL, which has a larger optic size, 5 millimeter to 6 millimeter, depending on the power of the ICL. And this gives a better quality of vision, and the chances of glare is minimized further, and night driving in the white population is better. It is available in myopic eyes for from 0.5 to minus 18 diopters. Toric lens comes with the addition of plus 6 diopters, cylindrical power correction, And in hyperope, we can correct up to 10 diopters, and again we can correct up to 6 diopters of the astigmatism. It is available in 0.25 diopter steps from 0.50 to -3 diopters, and beyond that it is available in a zero point 0.5 diopters of increments. The lens size in hyperopic eyes, we can get a smaller lens of 11.6, which is not very frequently available, but routinely 12.1, 12.6, and 13.2 millimeter size are frequently used. And in a very high myopes, when the large white to white is there, we can order for a 13.7 millimeter lens also. In hyperopic models are without the centraflow. That is a disadvantage as of now. And coming to the Indian counterpart, the IPCL, the good part is the design is similar, and there is a central opening in this. We don't require now the peripheral iodotomy to be made. But the good part is, another good part is that we can correct up to -30 diopters from -1 diopters, and in plus hyperopic eyes we can correct up to +15 diopters, and we can correct up to +10 diopters of cylindrical power. And in presbyopic lenses, we can have a +1 to +4 diopters of near add, and they can be customized as per the size, white to white sizing of the sulcus or scleral, the between the sclera on either side. So we can customize the sizing also. And so this is the presbyopic lens, which is also available. But I think Dr. Ramamurthy will be speaking on this. And it is indicated in the eyes from in the patients of 21 to 45 years of age. Refraction stability should be there in all these eyes from less than 0.5 diopter change in 1 year. It is for the LASIK. It can be used for LASIK rejects when there is a very high myopia or the corneal thickness is less than 500 microns with the large pupils, presence of dry eye, excessively flat or steep cornea when there is a keratoconus suspect. In such cases, also we can go for these phakic lenses. The contraindications are the presence of lens opacity, pseudo-exfoliation, coloboma lens, zonulopathy, pigment dispersion, or any previous ophthalmic surgery which is relative, and any other ocular pathology like glaucoma, intraocular inflammation, corneal degeneration dystrophy, macular pathology like CNVM or macular edema. Complete ophthalmic assessment, uncorrected and best corrected visual acuity, refraction, manifest and cycloplegic, complete slit lamp examination, normal IOP, open angles grade 3 to 4 Sheffer, and corneal topography and keratometry tomography, all is done. And in all these cases, endothelial cell count should be more than or equal to 2000, and fundus examination, and in the case it should be normal peripheral retina, or if there are any lesion, they should be treated beforehand by photocoagulation. The two important thing is the measurement of anterior chamber depth, which has to be looked upon, and it should be more than or equal to 2.80 millimeter, excluding the corneal thickness, and a corneal horizontal white to white distance should be measured. So this is the anterior chamber depth as I have depicted here. It should be internal anterior chamber depth, which should be 2.80 or more, and we have to check the white to white, and I do it in all my cases with digital caliper, as you can see on the bottom right side. And the other the things by which we can do it is OpScan, Pentacam, IL Master, UBM, vernier caliper, or some advanced autorefractometers. And this is how what we measure. This is depicted here, and this is a small video. Patient should be in a lying position under the microscope in high resolution from middle of the limbus to the middle of the limbus on either side. This is how it is checked. And pre-treat the eyes with anesthetic drops. This is 11.16, and we should calibrate the caliper before use. And sometimes in the when the arcus is thin or thick, or in juvenile arcus analysis, or in the allergic patient, then it becomes you find it difficult. But we have to measure it, and otherwise the vault will not be as good. Coming to the vault, accurate preoperative white to white and AC depth measurement is very, very important, because it is related to the presence of vault. Now, vault is the distance between the anterior surface of crystalline lens and the posterior surface of the ICL, as you can see, and it is in the bottom red arrow. And you have to compare this with the corneal thickness on slit lamp. So in this particular case, it is more or less same. So if we take the corneal thickness is around 500, so the normal this vault is around 500 microns. The normal vault is between 0.25 to 0.75 millimeter, or half the corneal thickness to 1.5 times of the corneal thickness. This comes in the normal category. If it is less than below 0.125 millimeter, then it is a low vault, and it can cause anterior subcapsular cataract. And if it is more than 1 millimeter, or double the size of the corneal thickness, then there is a chance of development of the cornea, glaucoma and pigment dispersion. And this is the vault which we can see on the left side, and the low vault on the right side. So now the ICL comes with this kind of a sheet, wherein you will see all the preoperative workup is mentioned over here. What is the spherical power with cylindrical power, what is the axis, what is the keratometry, anterior chamber depth, corneal thickness, white to white measurement. And on the right side, they will tell us which model of the lens, 12.1 millimeter in this particular case, and minus 14.5 diopters with plus 1.5 diopter cylindrical correction. And the expected residual refractive power will also be depicted. And this is how it comes, and this is the both the eyes of this another patient. And in this particular case, the corneal thickness was less, so that's why even in this low power of 3.5 and 3.75, we are doing a ICL. So I have done it in a power because some people don't want to go for the laser connection, or because it is a irreversible procedure, and less in 2 and 2.5 diopters power also we have done the ICL. And so all these case sheets are there which come along with, and this is the IPCL power, how they send the this thing. Now coming to the confidence which we all want to repose in all of you, that this is a recent means it came in December 2021, the 8 years outcome of implantation of posterior chamber phakic intraocular lens with a central port design for moderate to high ametropia. And you see the resultant power is very good, and in 8 years time the refraction and the results are predictable, and they remain the same, and there is no development of the cataract. So friends, it is a good option to do a refractive correction by ICL, and I thank you for your patient hearing. Any questions? We can take it now, or maybe later also.
I think very comprehensive coverage, Dr. Bhasin.
Thank you.
I mean, all delegates sitting here are competent anterior segment surgeons. I think more than the surgery itself is the correct evaluation and the decision when to operate, what lens to put in is most important, and you have covered it very nicely. One of the questions that's often asked is, yes, the cutoff according to the company was 3 millimeters earlier. Now they have dropped it down to 2.8 millimeters. What if the AC depth is 2.65 or 2.7? Is there a lower cutoff? Can you go ahead and implant in those cases?
The
Would you like to clarify on that?
Yeah, definitely. Sir, the company says that it is 2.8 millimeter, but in a personal way, I have done it in 2.7 millimeter also, and really the development of cataract and the vault is not an issue. Even with 2.7 millimeter, we can go ahead and do this thing, the phakic lens, in my personal experience.
I would slightly differ on this. Yes, Dr. Swaz.
Mike, please.
Please come to the mic. I would just like to clarify that I personally differ slightly on this, in the sense that I stick to a 2.8 millimeters, because you might do it on a 2.7 millimeter and get away with it. But the other factors, imponderables like lens raise and other things, which has an impact also. And doing a YAG iridotomy, when you have a central flow, really doesn't save you anything, because there's already a communication between the back of the lens and the front of the lens. So these are young patients in the prime of the productive life. So my take would be that, 2.8, 2.78, it's okay. And especially the high hyperopic, high myopic lenses, higher the power, the thicker the periphery of the lens. So these are the cases where you are tempted to make a compromise, and you might end up with a suboptimal outcome with the shallowing of the anterior chamber. So by and large, sticking to that standard of 2.8 is what we recommend across our centers.
I just wanted to know, since you have been doing ICL for a long, long time, have you in your patients observed that over a time the vault has decreased? Documented.
We have not documented. I have not documented personally, but we have this thing of 13 years old. We did it, and then we see those patients. Although during those days the central opening was also not there, but vault is still present, and no development of cataract is there, but definitely the incidence of cataract with the earlier type of lenses was high, and we come across now with the case of cataract in such eyes.
I think your question is very relevant, Dr. Suhas. All of us know that the lens thickens with aging. So that is a concern. We are operating on patients at 20, 25, and it has to subsist for them till such time as we go ahead and remove their lenses for cataract surgery. So because of this, it's also said that the lens thickens at the rate of about 0.1 to 0.12 millimeter for every decade of the lifetime of the patient. So obviously, if we say we are going to leave behind a 0.5 millimeter vault, in 20 years, this is going to come down quite. That's logical. But the thing is, this lens is not resting on the artificial lens that we are putting is not resting on the natural lens, but it is situated in the sulcus. And when this lens moves forward, there is also a commensurate movement of the phakic intraocular lens. So now the first phakic intraocular lens was implanted way back in 1988. And we have our own experience. We have almost a couple of decades of follow-up. And this kind of a shallowing of the vault is not something that's documented or established. Otherwise, all these patients would be landing up with cataracts 10, 15 years down the line.
So, in your experience, Dr. Ramurthy, what has been the minimum vault that you saw in your patient and just carried on, and you're happy that the lens is sitting there in spite of absolute proximity to the lens?
Absolutely. I think I'm going to actually be showing that in my presentation. We have cases with 84 microns, 100 microns vault, established, measured on the ASOCT. I'll be showing a picture of that also. As far as there is no onset of the anterior capsule is pristine, there's no onset of cataract, we really just follow up these patients. Similarly, again, what Dr. Bhasin said, 250 to 750 is our ideal way to go. We also have patients with 1,000 micron vault, where still the angles are open, more than 30 degrees open. There is no zipping up of the angles that's happening. We just follow them up serially, at least at a 6-monthly basis. So even though it's said that less than 150 microns, beyond 850 microns, you tend to exchange the lens, we are not doing it. But now the premise is that you follow up these cases for onset of the tiniest onset of any complications when you intervene.
If you see a lens opacity happening and the patient has no issues and continues to have good vision, would you still remove the lens?
I would, in the sense that if there is a small onset of anterior subcorpuscular cataract, which is happening a little peripherally, and I find the vault is about 85 microns, 100 microns, I will go ahead and exchange that lens.
But what's the logic behind?
Because you are going to put a higher sized lens so that the vault becomes bigger.
IOL exchange.
Yes.
Okay.
Because the vault occurs because the lens is slightly smaller than what it should be. So when you, supposing you have a 11 millimeter lens, and the Indian lenses are available at slots of 0.25, so you'll put 11.25 or 11.5 millimeter. So that will automatically increase the vault. We have done that also.
That's even when the patient has come 5 years later and now you start seeing a lens opacity.
Usually, these are problems which are seen within the first 6 months or 1 year of the patient. Supposing, 4 to 5 years later, this doesn't occur. And the good thing is, as was told by Dr. Bhasin, these problems were more when the central flow was not there. Now, not only the ICL, all phakic intraocular lens come with a central hole. And we find that because of the flow of the aqueous from the back of the lens to the front, the incidence of cataract is definitely less. Though I do see quite a few of my patients turning up now, patients whom we have operated 10, 15 years back with an anterior subcapsular cataract. And as you also know that these myopes are prone for early cataract. So if it's a nuclear sclerotic cataract, then it's really not the lens which is at fault. It's just that high myopic patients are prone for these cataracts, in which case you have to handle it.
So it's only those that are directly because of your ICL proximity, and if you see those opacity, that is when you'll intervene early.
Absolutely. Anterior subcapsular opacity. Usually it's a fibrotic opacity.
And I think when it is even early anterior subcapsular opacity, we can wait till it is not obstructing their lifestyle. Because then unless until it is progressed, I think
I would slightly differ on that, because once it comes to the center of the lens, the case is already lost. I mean, the natural lens has to come out. So when it happens in the periphery, you start seeing opacity coming up there. Then that's when you can rescue this case by just exchanging the lens. But supposing the opacity already crept on into the center of the natural lens, then obviously just exchanging the lens is not going to reverse that cataract.
If I can share one case, the patient came with a very small dystrophic error. He was not good for LASIK. We put a lens. He was 6'6" and 6, but his proximity, his vault was absolutely minimal. So we asked for a bigger. He had given the biggest. He gave one size bigger. That was the biggest lens ICL had. We put that lens, and then again he was 6'6" and 6, young patient, and his vault is, in spite of the biggest lens, was varying. That was another question I want to ask. It would some visit it would be 34, some visit it would be 70, some visit it would go up to 120, again come back to 50. This is going on for the last 7 years. He is still 6'6", but he has now reached 40. Now I told him, and he also knows, that I say, we are not going to do anything because your lens is so close. If I have to remove it, there's nothing I can offer you except that, do your lens exchange. And anyway, he's not high myope. So that means with such low vault, sometimes miraculously the lens survives, and we can,
I think you have brought out an excellent point, and that's what I'm going to also explain. And vaulting is not just white to white alone. It's also a function of the keratometric readings, the AC depth, the lens rise. All these factors are there. So that is the reason for the same amount of white to white, the same kind of power, you calculate and put an intraocular lens, the phakic intraocular lens, the kind of wall that you see in two different cases might be significantly variable. So my premise is, unless there is a complication, unless there is onset of a cataract, or if it's a high vault, unless there is a crowding of the angles, just watch these patients as you're doing.